Hello everyone. This is Mickey Eisenberg, and it's my pleasure to welcome you to the next podcast from the Resuscitation Academy Network. I'm especially thrilled today because our guest is Dr. Leonard Cobb, who, along with the fire chief, was the founder of the Medic One program in Seattle, and it went live in 1970. So this is the 50th anniversary of the Medic One program. I first met Leonard Cobb almost 50 years ago. It was a year later when I was a freshly hatched intern in the coronary care unit. And guess what? Leonard Cobb was my attending physician. And I recall very vividly seeing patients who had been brought back to life following a resuscitation in the community. So without further ado, let me introduce you to Leonard Cobb and ask the very first question. Leonard, tell us about those early years, 1970 when it went live, and what it took to get on the road, and did you face any obstacles that made you almost want to give up? What was it like?
Well, I guess the answer to all of those possibilities is yes. There were obstacles, there were problems, there were difficulties, but somehow or another, they kind of dissipated. We were encouraged by the work of Frank Partridge in Belfast, who described something he called a mobile coronary care unit. It was staffed by a resident from the Royal Victoria Hospital in Belfast and responded to general practitioners who went to the patient's home and requested help for a patient who appeared to have a myocardial infarction. And this was first attempt that I know about where organized medical care was provided outside the hospital on a regular basis. And we had ourselves and Mike Crowley in Los Angeles were particularly interested in the problem. What we in Seattle devised was a way of delivering medical care, not so much in novel devices and procedures, but in the delivery of care. Remember that by that time, which was 1969, we already had coronary care units, external chest compression, or as it was called, external cardiac compression, and defibrillation were on the agenda already. So, but we took these devices and put them into a unit that responded from the fire department's dispatch center, and staffed it at first with a physician, usually a resident, but in the nighttime, we had to volunteer from the faculty at Harborview Medical Center. And anyhow, that's how it got going. And we encountered a number of patients that had cardiac arrest. We responded quickly, and that was the one thing that was very novel to this program. We were able to get to the patient within a matter of 3-4 minutes rather than an hour. So anyway, we did encounter some very early cases, but surprisingly, they were not all myocardial infarction by any means. They were in fact cardiac arrest due to ventricular fibrillation usually, but not necessarily with acute myocardial infarction. So anyhow, that's how we got going, and that's some of the early findings. We always had a doctor aboard, and it was a resident in the daytime, and at nighttime, one of the faculty members, including myself, would ride the unit and provide medical care. There was a problem there in that there was no statutory authorization for such services without a doctor or at least a nurse's participation. So we did provide that for at least a year or a year and a half. Anyhow, that's Medic One in a nutshell.
Do you recall the very first save that you brought into the hospital who was in cardiac arrest when the unit arrived?
Well, I was on the very first dispatch for Medic One, 1970 in March. And we did have a cardiac arrest, but the patient did not make it to the hospital. About 3 or 4 days later, there was a subsequent one, and this patient did have ventricular fibrillation, was admitted to the hospital, and ultimately discharged home. He was unconscious for a couple of days, but went home and was in good neurologic condition as far as we could tell. So it happened pretty often, and we saw a number of patients, more than we anticipated, that had out-of-hospital ventricular fibrillation.
Did you meet any opposition either from the medical community or the nursing community to the idea of firefighters being trained and sent out in this fashion? Any resistance at all?
Well, no, I don't. There was nothing organized or final. There was a lot of bumbling, I think, and nurses were not always cordial to the medics when they arrived on the scene. But that was, by and large, those minor difficulties were gone within a few months.
Now, Seattle's been known for a very long time as one of the best places in the country to have a cardiac arrest, and that's largely due to the quality of the training program, but also to the high training of citizens in bystander CPR. Where did the idea for training the citizens, because there was no curriculum then for training, where did you decide that that was a critical component that needed to be addressed?
The reason this came about was kind of interesting. We always had 2 units at least on the scene. A nearby fire department, aid car, as they were called, which provided advanced first aid, or sometimes an engine company. But they were always on the scene, and they never sent out the mobile intensive coronary care unit by itself. So somebody generally was ahead of us. And this was a very important step in that care was available well before we got there. And so we decided it was all of the people manning the first arriving units were instructed about when and how to do CPR. And then the fire chief was convinced that we should have the whole department trained in when and how to do CPR. So this was done. So that was a major effort on our behalf. We had 1,200 individuals that I think were trained over a course of a few months. Well, one day, Gordon Vickery, the chief of the Seattle Fire Department, said, now, Leonard, if you can train firemen to do this thing, why not train the general public? I mean, the firemen are not naturally endowed with on matters relating to CPR. So we said, well, now that's a good idea. Let's proceed with that. So largely it was Vickery's idea to train the public. We got the local Rotary Club, downtown Rotary Club in Seattle, to support it, and they had some fundraising efforts, and a program which was called Medic 2 was introduced in Seattle. And I think this may have been the first organized effort to provide CPR training to the general public. So anyhow, this was, I think, a brilliant suggestion by the chief of the fire department. And this did encounter some opposition, but, with amongst the medical professionals, but it didn't last. And so within a relatively short period of time, the American Heart Association did sponsor courses in CPR. And it was, our efforts we didn't expect that people, the trainees, would be expert. And we've always sort of held the idea that it was probably more important for a lot of the population to be somewhat familiar with CPR and able to do it, maybe not perfectly, but as opposed to the other extreme and having just nurses and doctors trained to do it very well. So anyhow, I think CPR training of the general public was perhaps our single most important contribution.
Well, that's been a remarkable legacy, because I suspect the Seattle community and surrounding King County has the highest rate of bystander CPR really in the world, and certainly the highest trained rate of people. And it's certainly been a key ingredient. Well, Leonard, I thank you very much. It is truly an honor to be able to interview you. And we have known each other for many, many years, and I can't say there's anyone I admire more in the medical world than you. So thank you very much for being with us today, and just thank you.